introduction of the speakers here, and just wanted to say that our committee did through the foundation did a great job of gathering up this tremendous group of speakers that we have. We couldn't start this off without having the people who are the reason that we're all here sitting in this room today. The people who helped define this condition, did the research, did the publications, and continue to foster the care of all of our special children that are in our lives today. So without any further ado, I'd like to introduce Dr. Cara Skraban, Dr. Matthew Deardorff, Katie Grand, and Christopher Gregg.
So I'll kind of do a little bit of emceeing kind of throughout the afternoon as well, to try to kind of give transitions and intros as best we can. One of the things I do want to call out, and I'll point right at him, Dustin is the photographer you'll see him, obviously you've seen him coming around already, but taking photos for the session, the meeting as well. It's a lot of fun to kind of have everybody back in the room again. And really, I'll kind of just do a bit of an overview about what to expect, and then we'll get started. So really, the overview for really this afternoon and tomorrow, we're going to talk about some of the topics which I'm doing now. But the key areas for it, actually just one call out for, I'd say, the scientists that are here, Dr. Kudapa and Dr. Wild. There's a little different format than what we're used to of having people running around in the session, so it's pretty awesome, frankly. But the sessions that we'll kind of focus on will be really sessions around what we've learned around clinical insight. We'll have Dr. Skraban do a chunk, Dr. Katie Grand do a chunk, and Chris Gray do a chunk, to really help set up what we understand currently about the nature of Skraban-Deardorff syndrome. I can't even say that very easily still. We will then tackle a bit of the questions about what's evolving regarding what we understand about the science, and some of the research current status and which direction we want to be heading. I'll give a bit of an overall context with I'd say some general updates on things. Tom Frazier will call in and give us some updates on some of the neurodevelopmental studies. Kristen Subko is a genetic counseling student that worked with Katie in LA, who'll give us some feedback on one of her studies on sleep. Brenda Schulman will call in tomorrow morning about some of her work on the actual hardcore science around WDR26. We have Drs. Song and Kudapa are going to talk about some fruit fly models. And Dr. Weil will give us kind of a big view of different rare disorders and how you move forward in thinking about therapy strategies. At least that's, I'm assuming, what everybody's going to talk about. And then did it lock up on me? There. This is probably going to do a whole bunch of jumps here at once. And then kind of, I think another major important part of this is how we put together not just our clinical knowledge and our scientific knowledge, but how we actually apply this in real life. And the emphasis on how we are supporting families and some of the breakout sessions we're going to do around that as well. So that's kind of our big overview. And I will come back to this in terms of my content once Dr. Skraban, Katie, and Chris do their pieces. So I'm going to shrink this down and bring Dr. Skraban up here to give us the real scoop. If I can. All right. I think Dr. Skraban was making fun of me for not knowing apps, but is it up? Yes, and it's spelled correctly. Thank you. Any questions off of the intro? All right, good. These should work, or no, they were just sticking.
Okay, got it. Hello, thank you all for coming. Such a pleasure to be part of this family and to continue to work on this condition. I'm just gonna kind of give you backstory of the history of the condition and how we came to describe it initially in 2017. And then we're going to give just a brief overview of what we know about it from a clinical perspective. Matt was making fun of me because I spelt his name wrong in Deardorff on this first slide. And then he misspelled my name, but they're correct up there now. All right, so how did we get here? So as is the case with most of science, we start with one patient. And this was our first patient that came across our radars many years ago at CHOP, about 10 years ago, I think we decided that she came to clinic to see Matt. She had a test that many of your children had, which is called exome sequencing, which is essentially checking the spelling of all 20,000 of our genes to say, can we provide an explanation for this patient's symptoms? In most of your cases, those symptoms were very similar, things like developmental delay, low muscle tone, seizures. And when this test was sent on this little girl, she didn't have a clear diagnosis, but what they found was a change in a gene called WDR26. And at that time, it's what we call a candidate gene, meaning we found a spelling change in a gene. It's never been described to cause human symptoms before. It looks suspicious that maybe it's doing something, but we're not quite sure what. And so after this result came back, searched the internet to say, what do we know about this gene? The answer is not much 10 years ago. We did know that this gene was on on the first chromosome. And we think about chromosomes just as like road markers, if you will. So all of these numbers essentially just put the gene on a location on our first chromosome. So we all have 2 copies of our chromosomes. We have 23 pairs of those chromosomes. The first 1 through 22 are just numbered. And then the last set are our sex chromosomes. So this is a gene on our first chromosome, which is our biggest chromosome. And we have genes just scattered all across these. But we know that the WDR26 gene, does this work? Yep. Is located here, kind of at the tail end of this chromosome and falls within what was a already described condition called 1q41q42 microdeletion syndrome. And when we first found the change in this gene for this individual, we kind of looked in the medical literature and read what we know about the 1q41q42 deletion syndrome. So those kids have developmental delay, they have seizures, they can have short stature and a variety of different structural differences, club foot, cleft palate, etc. And they're also described as having differences in their facial structures compared to the rest of their family, what we call in the medical field dysmorphic features. And this is just a kiddo from the medical literature who has 1q41q42 deletion syndrome. These are more individuals from the medical literature with the condition. And I hope you can appreciate they all kind of have similar facial features as each other. They're obviously all their own unique individual, but they share some similarities in their faces. So there exists something called, well, there's multiple matcher sites in the genetics community where you can essentially say, I have an individual with a change in this gene. Does anyone else out there in the world, scientific world, also have a person with a change in this gene? It's a matchmaking site. This particular site that we use is something called Gene Matcher. So Matt put the gene in the matching site, and 3 years maybe or so later, he finally got a hit, and then we got more hits. We had another patient here at CHOP, and ultimately we found a total of 15 individuals. Some of their faces we can see here, who all had single changes in the WDR26 gene. Matt did some fancy science in the lab. that I'm sure he'll be happy to talk to you about later. And that ultimately led to our initial description of what we still call WDR26 related disorder in July of 2017. And this is just the title of that article in the medical literature. Again, just some more pictures from that publication that we put out in 2017. You can see maybe some familiar faces, but maybe some familiar characteristics as well amongst the individuals. When we looked at the people in the medical literature who were missing part of that first chromosome, we found that there were pretty similar features. Am I supposed to do something with that? Okay, great. I'm going to keep talking. What happens in the genetics world is once a new genetic condition is described, in this case, individuals with changes in the gene WDR26, I don't even know what to call it, OMIM enters new conditions into their database, and they give them names, right? And so what often happens is they will name genetic conditions after the first and last author. And so that happened to be me with Skraban and Matt with Deardorff. To be clear, the second name is the more important person in the description. But it's hard for us to call it Skraban-Deardorff syndrome because that's weird for us to have a genetic condition named after us. Certainly an honor, but something that takes us time to process. So since that initial publication in 2017, we've heard from more and more families, more and more clinicians, scientists, many of those of you sitting in this room, to learn more about the condition. More groups around the world published about their patients. As we all know, there's now a foundation, the Skraban-Deardorff Syndrome Foundation, that's been established now a couple years ago. That's run by the wonderful folks in this room. There's a very active Facebook group that we do not hang out in, but I think many, if not most of you do. And it's also registered with NORD. So a lot kind of happening in this space, especially over the past couple of years. So again, this is our first patient. And this is just describing the first 15 people that we published in 2017. Well, that's not true. So kind of total, sorry. We've heard of prenatal cases all the way to mid-adulthood. We've heard of a couple of cases where there's been multiple people in the same family. So essentially a child received the diagnosis and then a parent was diagnosed after that. Roughly equal numbers of males and females. And there's all different types of spelling changes or changes in the gene WDR26 that Chris and then Matt are going to talk about a little bit more. So I will skip that for right now. Patients are all over the world, 5 continents. I'm sure well, I can't speak for Antarctica, but I feel like they're in the other 6 continents over the world. We talked about how we have many, many countries, not only here in this room, but also watching us virtually. These are just cute kids. Again, many of whom are in this room that we've collected over the years. Again, I imagine some of you are recognizing some of these faces. Again, okay, so now I've made it to the original cohort. So again, that is 15 individuals that we published in 2017. We first described the condition to be largely a neurodevelopmental condition, meaning the primary presentation of those individuals focuses on the brain and how the brain functions, essentially. So, kids presenting with, or adults with developmental delay, so delays in their milestones, cognitive differences. All 15 of these original individuals had seizures. Some were described as having structural differences in their brains. low muscle tone or hypotonia and gait differences were pretty common. Behavior differences were described. So I don't believe any in this initial cohort were actually given a diagnosis of autism, though multiple individuals were kind of described as having autistic traits. And then again, talked about a common set of facial features. I'll show you more pictures of that in a second. Each year, we learn a bunch of information from the patients we see in clinic, the physicians and researchers that reach out to us all over the world, but most importantly from all of you. So you guys coming here, sharing the information about your patients and your families helps us tremendously learn more about this condition. We can learn far more about watching you interact with your children and probably more importantly, watching the children interact with each other to get a broader understanding. This is our picture of our family meeting from 2022. Happy to see many of the same faces in the crowd, but also importantly, new faces as well. I love pictures. There's just a lot of cute pictures available. But again, a lot of people in this room still growing up, right? So I have pictures of some of these children when they were much smaller and get to watch them grow up over time. So again, thinking about what we know and what we've learned over the years. So the core features of the condition remain. So again, it is a neurodevelopmental condition, meaning, closer to the mic, Chris tells me, meaning that for the most part, all kids obtain their milestones late. So sitting, walking, talking is later than what you would expect for their age. That can range quite significantly. And I would say as we continue to learn more about the condition and find more patients, we really get to see how wide that range is. As we've talked to many of you yesterday, today, in the past, the thing that these individuals struggle with the most is the ability to get their words out. So we know that for the most part, they understand pretty well, that they can follow directions, they know what's going on around them, but it's hard for them to get those words out and express themselves, certainly from a speaking perspective. And some of that we think is due in part due to oromotor dysfunction, so the actual ability to use our tongue and our mouth to make words, which is a much more complex thing than all of us think about in our day-to-day lives. Low muscle tone tends to be common. One of the true pleasures of working with all of you is that these kids are amazing. They're happy, they're friendly, they're outgoing, smiles everywhere, which truly makes it a pleasure. That doesn't mean they don't have anxiety, and we do see that in some kids. Some kids do have behavior differences, autistic features, or a formal diagnosis of autism. Many kids who are exhibiting those traits often don't end up getting a diagnosis of autism due to the fact that they're so engaged socially, right? So they're going to look you in the eye, they're going to give you hugs, they're going to be affectionate, and they want that interaction. And that's one of the core features of autism, which again is a clinical diagnosis, is at least in a subset of individuals, the difficulty in forming those interactions. They're out there causing trouble and it's making me nervous. Right. As I said before, the original 15 all had seizures. Since that time, we've seen that while a large percentage still have seizures, we have many patients at this point who do not have seizure activity. Some do still have changes on their EEGs, which is when they stick the leads on your head to read your brain activity, even though they might not have seizures. All kinds of different types of seizures, ranging from seizures we see with fever to more complex seizures to what we call absence seizures, or just staring off in space. They tend to be easy to control just with standard seizure medicines. Often the seizures resolve over time, and so we do see that often in later grade school, adolescence, where people say, we haven't had seizures in years, which is wonderful. Structural brain differences still is a common feature, but not seen in everyone. And also not everyone gets their brain imaged. And I don't think we all need to get images of our brains just to get it, unless there's symptoms that prompt us to do so. Skeletal differences are seen in a subset of folks, including some of the kiddos we've seen here, club foot, differences in the shape of the foot, including flat feet, high arched feet, contractures or limitations in fully extending or flexing our joints, hip differences, etc. And then there's a long list of other things, right? So again, the primary features that we see are neurobehavioral, but we do, in some individuals, have structural differences in other parts of our body. Structural differences in our heart, cleft palate or holes in the roof of our mouth, structural differences of our kidneys, things like failure to thrive, short stature, certainly seen in a subset, vision differences, frequent infections, low blood sugar issues. We did put out this recommendation for clinical care some years ago now. We should probably update this, but I would say still accurate what's in here. We just know more, but it's pretty easy to find. You type WDR26 in gene reviews into Google, you should be able to pull it up. So again, recommendations for care, for the most part, are based off of symptoms. So right now, what we know is how to manage symptoms that people have. So there are going to be other talks about treatment going forward, targeted treatment based off of the gene change. And that's certainly promising and exciting, but right now what we do is we manage symptoms of the individual as they present. So again, standard therapy for neurology, standard therapy for correcting vision or lazy eye. We do recommend that all individuals at least get their heart checked once to look for mild differences in the structure of the heart. And I would say that echocardiogram or the ultrasound of the heart probably being important for everybody at least once. Again, you're gonna evaluate the palate to see if there's a hole up there, what again we call the cleft palate. That's standard treatment if it's present. But ear tubes in a kiddo if they're getting frequent ear infections. One thing that we didn't recognize at all initially was the dental differences that people can have. So retaining baby teeth is common. I'm seeing a lot of people shake their heads. So the baby teeth not shedding on their own. So a dentist needing to go in there and pull baby teeth, I think is probably more common than we appreciated even 2 years ago. Treating, again, if a child needs help gaining weight, we're going to help them gain weight like you would with any child. These kids they're all growing up in these pictures. Development, again, is probably, since that's the biggest component of this condition, is our focus, and something we definitely encourage people to continue to give their child therapies. We're not going to put any limitations on these kids. We're going to keep pushing them to help them achieve to the best of their ability. And that is by providing them services and therapies, and by the wonderful care that all of you are already providing them. Goes a very long way to have dedicated and loving families. In the United States, we call it early intervention, which is services that are provided for kiddos under 3. So physical, occupational, speech therapy. ABA therapy tends to be helpful, at least in a good chunk of these kids. And that's a therapy, again, I'm not sure what's called in other countries, but here in the United States, it's based off of repetition and is a common therapy that is given to kids or recommended to kids who are on the autism spectrum. But we have seen it, and you guys have told us that your children, some of your children at least, have benefited from that type of therapy, even if they don't have a diagnosis of autism. So there's something about the way their brains work that we just know that this helps. And then, of course, there's plenty of emerging questions, some of which, again, we're going to talk about in subsequent talks, including assessing development, talking about the types of mutations, how that might impact symptoms that an individual ends up having, and then potentially our goal, as is the goal with anyone in medicine, is really, can we get to the point where there's a potential treatment to help these kiddos? Just some cute pictures from 2022. And again, I think, again, by being here, by seeing all of you, to see how engaged you are with your children, how you would fly across oceans and drive across the country to get here, shows us how lucky we are to be able to spend this time, share with what we know about the condition, and then have you guys share back to us about what you've learned about your children over the years, and again, to watch you interact. So truly a pleasure to be able to be here and speak with you guys.